Good morning, students. In this brief session, I'm going to answer the questions which were asked in second terminal examination. The first question is, Langer's lines are due to arrangement of collagen fibers in epidermis, dermis, hypodermis, none of the above. B is the correct option. Now, what are these Langer's lines? Skin consists of epidermis, dermis, and hypodermis. Collagen is present in dermis. The arrangement and orientation of collagen fibers in dermis determines direction of Langer's lines on surface of skin. So Langer's lines are produced by collagen fibers in dermis. These lines correspond to the natural orientation of collagen fibers in dermis. They generally lie parallel to the orientation of the muscle fibers. Incision is made parallel to these lines heal better and produce less scarring, thus are cosmetically better than those incisions which are given across these lines. So incisions are to be given along these lines, not across. So a transverse incision is given for thyroidectomy. As a consequence of it, we get better wound healing and cosmetic results. Incisional hernia is a common complication of which incision, midline, paramedian, pararectal, rooftop. Midline is the correct option. Abdominal pelvic incisions are divided into vertical and transverse. Vertical incisions include midline, paramedian, and pararectal. Transverse and oblique incisions include coccus, transverse muscle dividing, McBurney's, oblique muscle cutting, and Fensteel incision. Median incision or midline incision is a vertical incision which follows the linea alba. It may be upper midline incision, lower midline incision, or a single incision. This type of incision is favored for diagnostic laparotomy. Types of midline incisions are supraumbilical midline incision, infraumbilical midline incision, and midline incision for laparotomy. The structures which are cut during midline incision are secant superficial fascia, linea alba, fascia transversalis, extraperitoneal fat, and parietal peritoneum. Advantages of this incision are there is less bleeding, it is almost bloodless, there is no muscle cutting, no nerves are injured, it gives better access to the upper abdominal viscera. It takes less time, so this incision is preferred in emergency. Disadvantages of this incision are there is delayed and poor wound healing. It is not approved cosmetically. Post-operative incisional hernias are common. Infraumbilical incision may lead to bladder injury. During splenectomy, which structure should be ligated first? Splenic artery, splenic vein, both together. Splenic plexus of nerves. Splenic artery should be ligated before splenic vein. Spleen is supplied by splenic artery, which is a branch of the celiac front. It is drained by splenic vein, which is formed at the hilum of the spleen by joining of 3 to 4 tributaries which leave the hilum. Before reaching the hilum of pancreas, splenic artery gives branches to pancreas. One of the branches is larger. We called it as arteria pancreatica magna. Then, before dividing at the hilum, this artery also gives branches in the form of left gastro, epiploic for stomach, and short gastric arteries for fundus of stomach. Thereafter, it divides into many terminal branches which enter the hilum of spleen. As shown in this animation, it arises from celiac trunk, gives many pancreatic branches. It also gives left gastromental and short gastric arteries before dividing into 4 to 5 branches at the hilum. The commonest indication for splenectomy is splenic trauma. During this procedure, splenic artery is ligated and divided first. As shown, first splenic artery is ligated, then it is divided between the ligatures. This is followed by ligation and division of splenic vein. The advantages of this procedure are there is less bleeding because it is splenic artery which supplies spleen. When we are cutting the blood supply, drainage continues to be there. There is less bleeding and size of spleen decreases. This makes more. Which is the embryonic origin of spleen? Ectoderm, mesoderm, endoderm, midgut. Mesoderm is the correct option. Development of spleen. Spleen is mesodermal origin. It develops in dorsal mesogastrum during fifth week of intrauterine life in its left layer. Mesodermal condensations appear during fourth week. These mesodermal masses are called spleniculi. They fuse to form spleen during fifth week of intrauterine life. Notching of superior border represents fetal lobulation of spleen, as shown in this animation. Stomach develops in mesogastrium and divides it into ventral and dorsal mesogastrium. Spleen develops in the left layer of the dorsal mesogastrium during fourth week of intraembryonic life. Mesodermal condensations appear in dorsal mesogastrium. These condensations fuse with each other during fifth week of intrauterine life to form spleen. It is connected with the stomach by gastrosplenic ligament. Thus, dorsal mesogastrium is divided into ventral part, which extends between stomach and spleen and is called the gastrosplenic ligament, and dorsal part, which lies between spleen and left kidney and is called lienorenal ligament. Spleniculi join together to form spleen. Notching of the superior border represents fetal lobulation of spleen. At times, these mesodermal masses or spleniculi fail to fuse. They are called accessory spleens. Size of these spleens varies from peanut to plum. They are found in 20% of individuals. Common site where these spleniculi are found is gastrosplenic ligament and its derivatives, greater omentum, broad ligament, and suprametic cord. Here we can see the accessory spleens or spleniculi. Again, we can see these spleniculi in relation with the hilum of spleen. Now, gastrosplenic ligament, as already said, connects fundus of the stomach with the anterior lip of hilum of the spleen. This ligament contains short gastric arteries, short gastric veins, lymphatics, and sympathetic nerves. As shown in this animation, gastrosplenic ligament lies between fundus of the stomach and spleen, and splenorenal ligament lies between spleen and left kidney. It contains splenic artery with accompanying sympathetic nerves. It is also called lienorenal ligament. Phrenicocolic ligament, sustentaculum lenis, is a peritoneal fold extending from left dome of diaphragm to the colon. This ligament, in addition to supporting the spleen, it prevents the spread of infection from left paracolic gutter to the supracolic compartment of peritoneal cavity. As shown in this diagram, infracolic compartment is bounded on the right side by ascending colon, superiorly by the transverse colon and mesentery. On the left side, it is bounded by descending colon. It is divided by the root of mesentery into right and left infracolic spaces. Right infracolic space is triangular space. It is a closed one, in contrast to left infracolic space, which is open. Infections can spread from infracolic compartment to supracolic compartment through right lateral paracolic gutter. They cannot spread to the supracolic compartment through left lateral paracolic gutter because phrenicocolic ligament is attached there between the diaphragm and splenic flexure of colon. Communication between supra and infracolic compartments. The supra and infracolic compartments are connected by the paracolic gutters which lie between posterior lateral abdominal wall and lateral aspect of ascending or descending colon. The presence of this phrenicocolic ligament prevents spread of infections from infracolic compartment to supracolic compartment through left lateral paracolic gutter. As shown in this animation. The phrenicocholic ligament prevents the spread of infection from infracholic compartment to supracholic compartment through left lateral paracholic gutter as shown in this animation. Which of the following hepatic ligaments contains portal vein? Coronary, feldspar, teres, hepatogastroduodenal. Hepatogastroduodenal ligament is also called the lesser omentum. It lies between liver and stomach. That part is called gastrohepatic ligament, and the part lying between liver and first inch of the duodenum is called hepatoduodenal ligament. The contents of the pre-margin of the lesser omentum are common bile duct, hepatic artery, and portal vein. The arrangement of these three structures is two of them lie anteriorly in the free margin. Common bile duct, D for dextro, D for duct, lies anteriorly, and hepatic artery, A for anterior, lies to left and anterior, and portal vein, P for portal, P for posterior, lies posteriorly in the free margin. Which of the following is false statement about capsules of kidney? True capsule invests kidney. True capsule lines renal sinus. Anterior layer of the renal fascia is called fascia of Tolt. Paranephric fat lies between true capsule and renal fascia. Let us go to the coverings of the kidney. Each kidney has four coverings from within outwards. The first covering is called a true capsule. It is a fibrous capsule. Second covering is called fatty capsule or perinephric fat. Third one is called a facial capsule or false capsule. It is also called a renal fascia or fascia of Gerotor. And the fourth extraperitoneal covering is called paranephric fat. True capsule covers entire kidney, lines renal sinus, and walls of major and minor calyces and pelvis of ureter. It is composed of collagen and few elastic fibers. It also contains smooth muscle fibers. It gives shining appearance to the kidney. In healthy or disease-free kidney, it can easily be stripped off by giving a nick or incision. It becomes adherent in renal diseases, and its separation from kidney becomes difficult. Perinephric fat constitutes the second covering. It is a layer of adipose tissue which is traversed by a number of fibrous strands connecting true and false capsule. It is abundant along the borders of the kidney and extends through hilum into renal sinus. Third layer is called the facial capsule or renal fascia. It lies farther from the kidney. It is also called false capsule. It is a fibroalveolar sheath which surrounds kidney, and perinephric fat forms common covering of kidney and suprarenal gland. Anterior layer of it is called fascia of Tolt, and posterior layer is called fascia of Zuckerkundl. As shown in this diagram, it surrounds both kidney and suprarenal gland. Between the kidney and suprarenal gland, there is a facial septum. Anterior layer of this fascia is called fascia of Tolt, and posterior layer of this fascia is called fascia of Zuckerkundl. Above, the two layers fuse at the upper pole and then split again to enclose the suprarenal gland and then blend with the subdiaphragmatic fascia. Laterally, both the layers fuse and become continuous with fascia transversalis of anterolateral abdominal wall. Medially, the two layers fuse with the connective tissue surrounding aorta and inferior vena cava. Posterior layer is continuous with the psoas fascia. Along the medial border of kidney, the two layers are connected with each other by connective tissue septum. So anteriorly lies fascia of Tolt, posteriorly lies fascia of Zuckerkundl, superiorly the two layers fuse to enclose the kidney and then again split to enclose suprarenal gland. If we take a horizontal section, we see laterally the anterior and posterior layers are continuous with fascia transversalis of anterior lateral abdominal wall. Medially, anterior and posterior layers are separate. They are connected by a facial septum. The medially anterior layer is continuous with the anterior layer of opposite side, and posterior layer mixes with the source fascia, as also shown in this diagram, the fourth layer of paranephric fat. Now we go to this diagram to demonstrate the fourth layer of paranephric fat. So kidney and suprarenal gland are enclosed in the third layer, but they are separated from each other by facial septum. Superiorly, now to make things more simpler, let us go to this animation. So it is kidney which is surrounded by true capsule. Outside the true capsule is perinephric fat, which is surrounded by the fascia of Gerota. Outside the fascia of Gerota is the fourth layer of paranephric fat. Which of the following is a false statement? Abdominal cavity proper is the largest cavity of the body. Falus pelvis is included in abdominal cavity. Abdominal pelvic cavity is the largest cavity of the body. Peritoneal cavity is larger than abdominal cavity. D is false statement. Abdominal cavity is located between thorax and pelvis. It lodges important viscera. It is important clinically, and clinicians call it a magic box because most of the times pre and post operative diagnoses are different. Knowledge and experience is needed to solve clinical problems arising out of the developmental anomalies. The boundaries of abdominal pelvic cavity are: superiorly there is thoraco-abdominal diaphragm, inferiorly peritoneum lining the pelvic floor, posteriorly posterior abdominal and posterior pelvic walls, anterolateral abdominal and pelvic walls. Major part of abdominal pelvic cavity lies between diaphragm superiorly and inlet of pelvic cavity inferiorly and is called abdominal cavity. The part of abdominal pelvic cavity below the pelvic inlet is called the pelvic cavity. The two cavities are continuous with each other and both are lined by peritoneum. Which of the following structures is not included in the boundaries of epiploic foramen? Lesser omentum, portal vein, quadrate lobe of liver, inferior vena cava. C is the correct option. Epiploic foramen is also called as foramen of Winslow, adductus to the lesser sac. It is a slit-like opening. Anteriorly, it is bounded by free margin of the lesser omentum. Inferiorly lies first part of the duodenum. Superiorly lies caudate lobe of liver, and posteriorly lies portal vein. It is said that epiploic foramen lies between two great veins. Anteriorly, there is portal vein in the free margin of the lesser omentum, and posteriorly is inferior vena cava. Epiploic foramen opens into hepatorenal pouch of Morrison. Thus, infections can spread from lesser sac to the greater sac through epiploic foramen. Lesser sac is also called omental bursa. It is an irregular shaped recess of peritoneal cavity that is hidden behind lesser omentum and posterior surface of stomach. It communicates with the greater sac through epiploic foramen. It is also called omental bursa because the space acts as a bursa for stomach for its expansion and mobility. Fluid collection is in it displays stomach anteriorly as occurs in the pseudocyst of pancreas. Which of the following is a closed space? Right lateral paracolic gutter, right upper triangular infracolic space, lesser sac, left inferior infracolic compartment. B is the correct option. Boundaries of infracolic compartment. Superiorly, there is transverse colon and its mesentery called transverse mesocolon. A right lateral boundary is formed by the ascending colon. Left lateral boundary is formed by descending colon. Below and to the left lies sigmoid colon. Infracolic compartment is divided by root of mesentery into right and left infracolic spaces. Right upper infracolic space is triangular and it is a closed space as compared to left infracolic space which communicates with the pelvic cavity. Infections can go from infracholic compartment to supracholic compartment through right paracholic gutter, but they cannot pass from infracholic to supracholic compartment due to the presence of phrenicocholic ligament. The communications between supracholic and infracholic compartment are the supra and infracholic compartments are connected by paracholic gutters which lie between the posterior lateral abdominal wall and lateral aspect of ascending or descending colon. Infections cannot go from infracholic compartment to supracholic compartment through left lateral paracholic gutter due to the presence of phrenicocholic ligament. Phrenicocholic ligament, in addition to supporting the spleen, it prevents the spread of infection from infracholic to supracholic compartment. Which of the following causes effusion in the lesser sac? Rupture of duodenal ulcer, rupture of an ulcer lying on the anterior wall of stomach, rupture of an ulcer lying on the posterior wall of the stomach, duodenojejunal perforation. C is the correct option. In living stomach has two surfaces, anterior superior surface and posterior inferior surface, formed by anterior and posterior walls respectively. Lesser sac lies posterior to the posterior surface of stomach. So an ulcer along posterior wall of the stomach can perforate and contents from stomach can go into lesser sac as shown in this animation. Which of the following is false about mesentery? Is a double-layered fold of peritoneum transmitted blood vessels. Mesentery proper is mesentery of small intestine. Mesentery contains fat. Transmitted blood vessels only is the wrong statement. Mesentery is a double-layered fold of peritoneum which attaches gut tube to the abdominal wall. It is divided into ventral and dorsal mesentery. Ventral mesentery is present only in the region of the foregut, whereas dorsal mesentery is present throughout. The functions of the mesentery are it attaches the viscera with the posterior abdominal wall and supports them. It acts as a conduit for blood vessels, nerves, and lymphaticus, and it also contains fat. On sonographic examination, liver is said to be enlarged if its length exceeds dash centimeters 12, 11, 13, 16. D is the correct option. Length of the liver is not given anatomical books because it is a well-shaped structure. But in sectional anatomy, by using ultrasound, we measure the length of liver from diaphragm to the lower pole of the kidney by placing a probe either in mid-clavicular or in mid-axillary line. Up to 16 centimeters, we take length of the liver as normal. In a sagittal section, if the length of the liver exceeds 16 centimeters, we say it is enlarged liver. The common cause of enlarged liver is fatty liver, and the commonest cause of shrunken liver is cirrhosis. Thank you for watching this.